first-year child psychiatry fellows. So it's okay to record here. And so today I'll be talking about stress sensitivity and early psychosis in particular. My faculty support on this is Dr. Carol Chen, who's on the call, and Dr. Steve Taylor also kind of helped out with the slides and kind of developing the topic. Okay, so first we'll cover what stress sensitivity and vulnerability is as a concept, and then we'll talk about some of the underpinnings of it from a neurobiologic and psychologic perspective. Then we'll cover how we measure stress sensitivity as a way to make it a little bit more concrete. And then some studies that are relating it to early psychosis in particular. And then lastly, we'll finish up on some interventions. So stress sensitivity is a pretty transdiagnostic concept, but I feel like it doesn't always seem to be captured well in our different like depression rating scales and other things that we use to assess symptoms. Clinicians working with folks with schizophrenia in particular may notice that their patients are tend to exhibit more fragility to minor stresses. And these negative affective states appear to be in contrast to the emotional deficits that we now incorporate into the concept of negative symptoms. So one way to conceptualize the relationship between stress sensitivity and psychosis is with this stress vulnerability or stress diathesis framework, which was first formulated for schizophrenia like over 40 years ago. The idea being that psychosocial stress may contribute to the development of psychosis in vulnerable individuals. So stress is assessed in terms of events along our y-axis here and vulnerability along our x. And it's this vulnerability itself that I'll kind of be talking about today. So the idea with this framework is that in those that are vulnerable to stress, it takes less exposure to stress to lead to the development of psychosis symptoms. Okay, so we'll use this as our working definition of stress sensitivity as the tendency to experience negative affect, which I'll refer to as NA in the text in the slides here, in response to settings that are not ordinarily considered stressful. An alternative way of thinking about this is that stress vulnerability reflects a reduced capacity for engaging with the environment. So with a reduced capacity, the threshold for what makes an event stressful is lowered. So it's interesting to know that negative symptoms can belie this, the presence of stress vulnerability. And a recent meta-analysis showed that patients with schizophrenia tend to have more negative affect compared to healthy controls. And while our focus today will be on stress sensitivity / vulnerability itself, depression and anxiety may be downstream complications of impaired stress tolerance. As I mentioned before, stress is assessed in terms of both the vulnerability and exposures. And the literature suggests that patients with early psychosis don't experience more stressful life events than others. It's just that they respond to them more negatively, which suggests that maybe something else other than just the presence of stressful events is kind of driving this, this vulnerability. Okay, so we have our working definition of stress sensitivity, and now we'll cover a hypothesis about the pathophysiology. So this is the conceptual model for stress sensitivity here. It may seem a little bit daunting at first, but we'll kind of go through it, and it's fairly straightforward. First is that while I'll be talking primarily focusing on psychotic illness, this model is in several ways quite transdiagnostic with disruptions of GABAergic parvalbumin interneurons, which is something I'll cover in the next few slides here, representing like a final common pathway for a lot of mental illness. And several of the risk factors for this in psychosis are also risk factors for other psychiatric illnesses. So kind of going through the model here, stress vulnerability is conceptualized as driving negative affect, which itself is comprised of different phenotypes that can be measured, including anxiety, depressive mood, and general distress. This vulnerability also, at least in part, mediates symptoms of impaired cognition and positive symptoms like delusions, hallucinations. Not all negative affect reflects vulnerability to stress. So situations like somatic pain or drug side effects may directly lead to negative affect. Environmental threats like poverty and discrimination may also directly cause this and are likely mediated by someone's vulnerability to stress. So this model also includes factors that are associated with the development of schizophrenia, environmental stresses in early life and adolescence, like social deprivation, obstetric complications have been linked to schizophrenia, And childhood trauma stands out as a risk factor, occurring in up to 1/3 of patients with schizophrenia. And that's something we'll kind of touch on a little bit in the next few slides here as well. And genetics also kind of serve as another possible etiological factor. So specifically, the hypothesis is that this vulnerability to stress is linked to abnormalities in GABAergic parvalbumin interneurons. And over the next few slides, I'll kind of do a high-level review of some of the neurobio behind that hypothesis, and then talk more about like trauma and its relation to stress sensitivity. So I just want to give a high-level review of some of the neurobio terms here. So interneurons are the neurons that connect brain regions, as opposed to providing sensory information or leading to motor activity. Within the cortex are specific interneurons that express a protein called parvalbumin, which is involved in different like cellular second messenger systems within the neuron itself. So these specific interneurons, called PVI throughout the rest of this talk, release GABA, which is the primary inhibitory neurotransmitter in the brain. And damage or disruption to these interneurons have been implicated in a number of different psychiatric disorders. So I just wanted to highlight a couple of quick points on terms of evidence for disruptions of parvalbumin interneurons in stress sensitivity and schizophrenia. There are additional studies in animal models and kind of in the kind of GABAergic system in general in schizophrenia, as well as other studies in other disorders, but those are outside the scope of this talk. Within postmortem studies of patients with schizophrenia, we find that there's reduced parvalbumin and GAD67 expression. And GAD67 is the synthetic enzyme for GABA. There's also structural abnormalities around parvalbumin interneurons that are seen throughout the cortex and hippocampus. And disruptions to these neurons may lead to an excitatory inhibitory imbalance in the brain, which is hypothesized to drive at least some of the findings in schizophrenia, like aberrant salience. And the evidence suggests that these changes are not due to confounding factors like age or medication.
Hi, this is Megan Julian calling you back from the Infant and Early Childhood Clinic.
I'm sorry, I think Megan, you might be unmuted there. Okay. Okay. And so as an aside, I just want to include this quickly about the impact of stress on these interneurons. So this review article discussed how parvalbumin interneurons appear to be impacted by early stresses via changes due to oxidative stress. And this has been tightly associated with psychologic stress as well. So going back to our model, this serves as a potential biologic connection for childhood trauma and future emotional dysregulation and stress vulnerability. They further hypothesize that exposure to adversity sensitizes the mesolimbic dopaminergic system, which has been implicated in the positive symptoms of schizophrenia, like delusions, hallucinations. Okay, so for some specific contributors to stress sensitivity, I wanted to touch on trauma first. We could do a whole talk on trauma in this population, but I just wanted to highlight a few high-level points before covering a study specifically on childhood trauma and stress sensitivity. So CHR is an acronym we'll use throughout this talk, and it refers to clinical high risk, which is a categorization of patients based on the presence of at least one of three criteria. So that being attenuated psychosis symptoms that are maybe limited in terms of their intensity or frequency, a history of a brief self-limited psychotic symptom that resolves within 7 days, which is the SPLIPS acronym, or a positive family history of psychosis plus persistent low functioning. So this is like the prodrome to having a first episode of psychosis. So FEP will kind of be first episode psychosis through this talk. There are wide ranges of trauma in this population, but the largest meta-analysis suggests that there's a prevalence of 46% of patients in this cohort that have experienced some trauma. In this population,
and dial 866.
Sexual and emotional abuse compared to controls. The transition rate from being high risk to having a first episode of psychosis can vary widely due to ascertainment strategy, diagnostic instrument, follow-up period. The largest study suggests a conversion rate of about 35%. And sexual and physical abuse were the traumas most likely to be associated with later psychosis conversion. Of note, there can be early symptom overlap between PTSD and psychosis. So it's important to be vigilant for psychosis when working with a trauma population, as symptoms may be misattributed to one piece of their presentation. And lastly, as of 2017, and then my own search, I couldn't find any trials of interventions on childhood trauma in like a high-risk population. So definitely an area for further study. So this study highlights how traumatic experiences impact stress vulnerability in psychotic illnesses. And they use a method called experience sampling method, which is a protocol I'll cover a little bit more in depth here because another study I talk about a little bit later on also uses it. Essentially, this means that patients were prompted to record their daily current mood, experience, and stress 10 times a day for 6 days. So they're prompted with like a beeping reminder to do so, and they complete a Likert scale of different statements. And Likert scales use like I agree to I disagree statements. So they had patients use these scales to evaluate how stressful they found their current activity, which they labeled activity-related stress, as well as significant events between recordings, which they called event-related stress. In addition to stress, they were also looking for psychosis symptoms and negative affect, with items asking about feeling down, guilty, anxious, insecure, etc. And they also assessed for childhood trauma as part of their intake. So for this table, the cohort was divided into high trauma groups and low trauma groups. And they looked to see if stress predicted negative affect and psychosis symptoms. And they found a significant interaction between activity and event-related stress and trauma in the model predicting negative affect. And they found similar results when they were looking for an interaction between childhood trauma and stress in the model predicting psychosis. So the main takeaways here being that there was an interaction between stress sensitivity and childhood trauma on both the development of negative affective symptoms and psychosis symptoms. These are small effect sizes, but the authors know that this is sort of typical of this, this protocol, this method of methodology. And some limitations include that this methodology is a subjective self-report, though it's been pretty well validated in this population. And this is also a cross-sectional study, so they can't really infer causality. Okay, and then lastly, on the topic of contributing factors to the development of stress sensitivity, I wanted to touch on the hypothalamic pituitary adrenal axis. There's a lot, there's like a whole wormhole you can go down in terms of like this, like stress hormone dysregulation in this population. But overall, the main takeaway is that there's some dysregulation of this axis in schizophrenia. In brief, the axis regulates stress responses via the release of certain hormones. So the hypothalamus releases corticotrophin releasing hormone, which triggers release of hormones from the pituitary, and then ultimately cortisol release from the cortex. And this stress cascade is mediated by projections from the hippocampus, the amygdala, and cortex, which are all areas that have been shown to have abnormalities in psychotic disorders. So while there's some conflicting evidence, the general consensus seems like that in patients with psychosis, we see elevations in baseline cortisol levels. Antipsychotics appear to reduce these levels. And in addition to an elevated baseline of cortisol, we also see blunted cortisol response to stress. So putting this all together, one theory about HPA axis dysfunction we see in psychotic illnesses is that there's an impaired ability to regulate stress, aka stress sensitivity, which can be the result of a number of factors. With higher stress vulnerability and more stress response, there are higher levels of cortisol, and hypercortisolemia has been shown to lead to hippocampal volume loss and dysfunction, which has been shown in schizophrenia. And this may produce alterations in dopamine release from basal ganglia and prefrontal cortex, contributing to symptoms of psychosis. So kind of another piece of this fairly complex puzzle. So I just wanted to summarize a few of the facets of the stress vulnerability model we've covered to this point. We talked about some of the evidence for disruptions of GABAergic parvalbumin interneurons in schizophrenia, which can be impacted by a variety of insults, including psychologic stressors like trauma. The dysfunction of these neurons then has implications for different neural circuitry in various areas of the brain implicated in symptoms of psychosis, and in particular for us, stress vulnerability. So the dorsal medial prefrontal cortex, dorsal anterior cingulate cortex are of particular note. And we also talked a bit about the HPA axis leading to cortisol dysregulation. So kind of putting this all together is a fairly complex picture, but one kind of hypothesis about how some of these things are working together. Okay, so sense stress sensitivity is a latent construct, meaning it's not directly observed, but has to be inferred by other measures. I thought it would be useful to include a discussion of a few of those as a way of making things a little bit more concrete and useful for actual practice. So we'll talk about a few of the scales used and then return to talking about cortisol a little bit. So there are a few different scales used to measure stress sensitivity. I mentioned the perceived stress scale at the top here because it's the basis for the psychological stress index 9 or the Psy 9. And that's what I'm going to highlight over the next few slides because it was developed here and is used in the prep clinic. So it'll be the one that you will most likely encounter. We also touched on experience sampling method as a means of rating stress sensitivity. And then within assessments of high-risk individuals, there are some subscales that evaluate stress intolerance. So one that we'll see in a few papers later is within the scale of prodromal symptoms, which I'll call the SOPs, and the comprehensive assessment of at-risk mental states, or the CARMS, also has a subscale on it that we'll talk about in the next few slides. But first, I wanted to cover the Psy 9, as I mentioned, it's used here. This was initially adapted from the perceived stress scale, which assesses the degree to which one appraises situations in life as stressful. And the goal of this scale was to capture the susceptibility of patients with schizophrenia to experience more negative affect from daily life stressors. It's a self-report scale, and the stressors captured include interpersonal interactions, personal responsibilities, social expectations, novel situations. And so to assess the reliability and validity and predictive value of this tool, they assessed 37 patients with schizophrenia, age 18 to 60, which is a bit older than our typical population, and compared them to 30 healthy controls. And they also looked at different 12-month outcomes during this process as well. So both the Psy 18, which is the full form of the tool, and then the Psy 9, which is the abbreviated version, had good levels of internal consistency. Alpha values were 0.88 and 0.86. The schizophrenia cohort scored higher on both versions of the tool compared to healthy controls. And then they did a logistic regression analysis, and schizophrenia versus healthy control could be classified in the basis of the Psy 18 score with an overall accuracy of 83%. And then with the Psy 9 tool, 82%. So this table is a little bit, has a lot going on, but we'll kind of just go through it piece by piece here. Basically, it's summarizing correlations between measures of stress, negative affect, and clinical symptoms among the schizophrenia group. And so both versions, if we're looking at column 1 and 2 here, both versions of the Psy 9 were highly correlated with the perceived stress scale. Looking across columns 4 through 8, which are different measures of clinician and self-reported negative affect. Both tools showed good correlations with negative affect, though the Psy 18 seemed to have stronger correlations compared to the Psy 9 tool. If we look down here at columns 10 and 11, these are both scales that are assessing negative symptoms. And you'll see that the scores on this test were inversely correlated with negative symptoms. And this seems kind of counterintuitive at first blush, but other investigators have reported an association between more negative symptoms and less negative affect. So with less intrinsic drive and motivation, negative syndrome patients might not engage in situations that would lead to a stressful interaction, hence the inverse correlation. So the main takeaways here being that the psychological stress index showed correlation with markers of both stress and negative affect, as well as, sort of an expected inverse correlation with negative symptoms. Both versions of the psychological stress index were moderately correlated with current and 12-month functioning per the social adjustment scale, which is down here. This covers 6 areas of functioning, including work, social and leisure activities, and relationships. In terms of 12-month outcomes, the Psy-18 significantly predicted the number of 12-month interval hospitalizations, and the Psy-9 also predicted days of hospitalization, number of psych ED visits, and number of hospitalizations as well. Whereas the perceived stress scale didn't significantly predict clinical outcomes. So overall, this is a tool used here in the PrEP clinic to assess stress sensitivity, has been linked to outcomes in a cohort of schizophrenia patients. One of the things we're kind of working on right now and have an IRB for it is like looking at if this tool predicts outcomes within more of a high risk and first episode cohort more specifically, so like a younger demographic. I just want to include this slide on cortisol because there's been like a lot of studies on stress hormones and schizophrenia. As I mentioned, baseline cortisol is generally found to be elevated. This was a systematic review that looked at studies of cortisol in a high-risk population and to look to see if there are any associations with symptomatology encompassing positive symptoms, negative symptoms, depression, anxiety. Within 3 of the studies that they looked at, stress tolerance was evaluated using that subscale on the scale of prodromal symptoms. And in 2 of those 3 studies, there was an association between cortisol levels and impaired stress tolerance. And then there was a trend level association in the 3rd study. Cortisol is like really difficult to interpret from what I'm gathering. It's not very practical. It's not something super useful for actual clinical use, but one thing I just wanted to include as an aside. Okay, so we've talked about stress vulnerability as a concept and how we attempt to measure it. In the next few slides, I just want to highlight a few studies that apply this concept more specifically to a clinical high-risk cohort or first episode cohort, and particularly how stress sensitivity may relate to the transition to full psychosis. So while the evidence for specific stressful events triggering an episode of psychosis is weak to non-existent, so like the death of a parent causing an episode of psychosis, there does seem to be a relationship between the inherent vulnerability to stress and the progression of illness. So the purpose of this study was to validate the CARMs, but in the process, they also evaluated stress intolerance in a clinical high-risk cohort. So this tool is a semi-structured interview that is pretty comprehensive since the name, includes subscales on disordered thought content, perceptual abnormalities, emotion and affect, and most importantly for us in this talk, impaired tolerance to normal stress. So scores on each subscale range from 0 to 6. And they compared the tool in a cohort of patients defined as clinical high risk by doing monthly evaluations over a year. And as you can see from the table at baseline here, there's differences in across all scores in the high risk group compared to controls. They use UHR, ultra high risk, and the same thing as clinical high risk. And in particular, the stress tolerance subscale was significantly different between the high risk group and the healthy controls. So they were primarily concerned about the transition from being high risk to having an episode of full psychosis. And about 40% of their cohort transitioned to an episode of a first episode of psychosis within their year of follow-up. So they then looked at which symptom domains within the CARMs may predict transition to psychosis using a regression analysis. And impaired tolerance to normal stress appeared to be predictive of transition to psychosis. Overall scores on the tool and intensity of negative symptoms were the most predictive. So the main thing I want to highlight here is that there's some early evidence, this is from 2005, that impaired stress tolerance may in part predict transition to full psychosis. The authors speculated that difficulty coping with stress may precipitate transition from non-distressing positive symptoms to distressing positive symptoms. Okay, so this next study was a cross-sectional and longitudinal study looking at a cohort of 65 high-risk patients and 24 healthy controls assessed quarterly over 4 years. And they were looking for associations between stress sensitivity and exposure to stress, so self-reported life events here, with the development of psychosis symptoms. And here's both stress tolerance and the psychosis symptoms were measured using the scale of prodromal symptoms. The baseline scores are included here. It's a little hard to read, but the high-risk cohort had statistically significant higher impaired stress tolerance scores, 2.8 versus 0.1, but comparable, if not lower, self-reported life events compared to healthy controls. So in their longitudinal analysis with correction for multiple co-founders, they found that impaired stress tolerance was associated over time with a range of prodromal symptoms, which included positive symptoms, specifically unusual thought content and suspiciousness, depression and anxiety, and poor functioning per the global assessment of functioning. It's not included here in this table, but also total negative symptoms and thought disorganization were also correlated. So these associations of impaired stress tolerance with symptoms could not be accounted for by demographics, exposure to medications, substances like alcohol or cannabis. And of additional note, self-reported life events were not relevant as a clinical correlate, which kind of goes back to that early statement about how specific life events don't necessarily trigger psychosis. So this study did require retrospective recall of stressful life events, and it only used the single instrument for both psychosis and stress intolerance, which is a limitation. Okay, so this last study aimed to investigate whether elevated stress sensitivity, experiences of aberrant novelty and salience, and enhanced anticipation of threat contribute to the development of psychosis in daily life. And so for us, the most important piece is the stress sensitivity component. So they use the experience sampling method we talked about earlier. Again, it's a self-reported diary of patient experiences recorded 10 times a day for 6 days. This table is just like it's a wall of text on purpose. It's really just showing that there's some different examples of questions that they use within the assessment to assess for different domains of stress, like event, outsider status, area-related status, or stress, as well as negative affect, and some of these other kind of early psychosis symptoms. Okay. So this table covers the aggregate scores for the different domains assessed by their protocol. And compared to healthy controls, both patients that have had a first episode of psychosis and those that are high risk had more activity, social, area, and outsider related stress compared to healthy controls. Both groups also experienced greater negative affect compared to controls as well during this assessment period. And as a side, they were also looking at aberrant salience, threat anticipation, and psychosis, which were all more common in both the first episode and high risk cohort. And they're using ARMS here as the acronym for clinical high risk. So from this table, the main takeaways are that in all groups, including the controls, elevated stress sensitivity was associated with psychosis experiences, which included ideas of reference, thought broadcasting, hallucinations, and paranoia. In terms of limitations, this data was from a subjective self-report, though this process has been kind of validated with prior work in the population. And because it's cross-sectional, they can't comment on the causality of their findings. They would need a prospective design. So overall, the takeaways here being that stress sensitivity has an association with the development of psychosis symptoms and negative affect, in particular in the high-risk cohort and the first episode cohorts. Okay, so we've talked about the different concepts and measurements and how it relates to early psychosis, but what do we do about stress sensitivity? I'll say up top that there really haven't been any clinical trials or studies that I could come across that were specifically looking at stress vulnerability in this population. Most studies, treatment studies of patients with high risk for psychosis or first episode psychosis really focus on primarily diminishing the traits, the transition to a full chronic psychotic disorder, with the reduction of symptoms like stress sensitivity usually as a secondary aim. So some of what follows is from a meta-analysis from 2018 of 41 studies of interventions in a clinical high-risk population that used psychosis symptoms as a primary outcome. These symptoms were assessed across a number of different scales like the BPRS and PANS, but they also included subscales or scales that had elements about stress intolerance as well. However, the data does not go into like that granular of detail for us to kind of suss out, which interventions might have helped with that specific piece of each scale. So I'll keep the results of it pretty high level because it's kind of only tangentially related to the talk. There are some other studies that we'll touch on that weren't included in the meta-analysis that might be a little bit more relevant too. So I just want to include the forest plots from that meta-analysis. This is the one from 2018 I referred to for two reasons. One is to cover what interventions they looked at, which included CBT, family-focused therapy, something called needs-based interventions, supportive therapy. And then from a pharmacotherapy standpoint, they also looked at antipsychotics, NMDA receptor modulators, and omega-3 fatty acids. Two is the overall message I want to leave you with from this meta-analysis and studies of current interventions that we have to address psychosis symptoms in a high-risk population that hasn't had a first episode yet have limited efficacy. As you can see, compared to placebo here in both the 12-month and 6-month network meta-analysis, none of these interventions appeared to separate from placebo. The error bars are quite large, so there's not a ton of precision in the studies. So, like I said, limited efficacy, and we know even less about how we intervene specifically on stress sensitivity. So that's kind of just, you know, a high level overview and kind of the general gist of what we'll kind of talk about over the next few slides. So first we'll cover psychotherapy interventions, which primarily focus on CBT and family therapy, and then we'll talk about like medications. So first I want to cover the results from the meta-analysis in 2018 as they pertain to CBT. So APS in this context refers to psychosis symptoms, and they use a number of different scales, as I mentioned, like the assessment of positive symptoms, the brief psychiatric rating scale, the PANS, as well as some scales that we've already encountered, like the SOPs and CARMs, which include elements on stress intolerance. However, the meta-analysis here said that CBT did not have a significant result in a significant reduction in symptoms compared to controls at 6, 12, and 24-month follow-ups. And in their 6 and 12-month network meta-analysis, it was not significantly more effective at reducing symptoms compared to any other intervention. As an aside, I didn't include it here because there's a ton of caveats to it, but they did something called surface under cumulative ranked area plotting, or SUCRA, which basically gives like a numeric ranking of the different interventions. And CBT did rank the highest compared to their other interventions, but again, you know, when they kind of look pairwise, there's no significant difference between it and other interventions. So there's a lot of caveats to that ranking. So there are two more recent studies of CBT that I wanted to cover. The first is utilizing CBT in a high-risk population, looking at depression, anxiety, and the transition to psychosis. And this was done in Italy, where they assigned 58 high-risk patients ages 16 to 35 to either 30 weeks of CBT with a focus on psychosis symptoms and affective symptoms, or 30 weeks of, or 30 sessions of supportive therapy. And the reason I included this one, A, is because sometimes we have to use negative affect here as almost like a proxy for stress sensitivity, even though it might not be entirely driven by stress vulnerability. The other reason is their CBT protocol also had specific topics that were relevant to this talk. So they covered skills on emotion management, challenging catastrophic thinking, and enhancing self-efficacy and managing daily life, which I thought was all pretty germane to what we're talking about. So they looked at the transition to psychosis and remission of affective symptoms after treatment, and then at a 14-month follow-up. There were no significant differences between groups in baseline in terms of their anxiety or depression disorders, substance use, medication use, or scores on the CARMs for like their psychosis symptoms. So for the depressive symptoms, a higher number of individuals receiving CBT achieved remission per the Beck Depression Inventory compared to controls at both post-treatment and then at follow-up about a year later. And this result was confirmed when they did the analysis only on participants who had reported clinically significant depression at baseline. So 57 versus 7 and 88 versus 22 here. The results for anxiety were similar. A higher number of individuals who had CBT achieved remission per the Beck Anxiety Inventory at post-treatment and follow-up. And again, they did the same analysis with patients that reported clinically significant anxiety at baseline and confirmed the results. So some limitations of this study include a small sample size. They also didn't have a broad screening procedure. The way they recruited participants were through referrals, so it was all kind of help-seeking individuals. I didn't include it in the slides, but the cumulative probability of being a converter at follow-up here was 12% for the CBT group and 34% for the control group. Okay, so then this is the last study of CBT I wanted to include. This was done in Norway. It was the first randomized controlled trial focusing on whether CBT for depression symptoms and low self-esteem could be superior to treatment as usual. And treatment as usual here refers to just standard medication and case management. And so this was done in a cohort of patients who were in the early phases of psychosis. So they already had a first episode of psychosis, as opposed to being in that high risk bucket. The reason I include this one is that they specifically note using the stress vulnerability model to explain psychosis symptoms as part of their psychoeducation component to their CBT. And they also looked at signs of negative affect, like depressive symptoms and self-esteem, which we hypothesized previously is at least driven in part by stress intolerance. I put a question mark next to the age range, which I thought was kind of strange to me. It made me kind of wonder about the diagnostic makeup of their population here. They included patients that had a maximum of 2 psychotic episodes or a max of 2 years of treatment for psychosis, which might have skewed the results or the demographics there. They also, patients had to be diagnosed with a depressive episode as well. And so they looked at different outcomes, including the Beck Depression Inventory, the Calgary Depression Scale, and then the Rosenberg Self-Esteem Scale, as well as the PANS and Global Assessment of Functioning. So for the primary outcomes of self-esteem per the Rosenberg scale and depression per the BDI, there were no significant differences between CBT and treatment as usual across their different time points. Both groups had improved over the course of the treatment with sustained improvements at the 15-month follow-up period. And then on secondary measures, they found an improvement in the negative symptoms per the PANS for the group receiving CBT compared to treatment as usual. And then also for the global assessment of functioning at the 15-month follow-up period for the CBT group as well. So some limitations include the sample size in this one as well, which might have been underpowered to detect differences between groups. But overall, the CBT group did seem to help with depression and self-esteem, though benefits weren't significant over treatment as usual. They also did a bit better on negative symptoms and global functioning assessments. Yeah, and I think the authors, if I remember right, said that they couldn't actually really assess what the treatment as usual exact protocols that they were following. So they might have been working some CBT into their med and case management. Okay, and then just going back to that network meta-analysis really quickly here for family therapy, the authors found that family-focused therapy was not more effective at reducing psychosis symptoms in this high-risk cohort compared to any other intervention. However, there's only one randomized control trial to that point, and so the results really should be interpreted with caution. They did know that there have been 3 observational studies of family therapy in a high-risk cohort that seem to have favorable results too. Okay, so now just kind of moving on to pharmacologic interventions, and then we'll wrap up here. First, we'll cover the antipsychotics as they were included in the meta-analysis, and then touch on antidepressants and GABAergic agents. So this is going back to the network meta-analysis. Risperidone plus CBT was not associated with a significant reduction of psychosis symptoms compared to treatment as usual at the 6 and 12-month time points. The forest plots are included here. There's only 2 studies that were included. but they even seem to skew more towards treatment as usual. In the network meta-analysis, risperidone plus CBT was not more effective than any other intervention. And studies of other antipsychotics like ziprasidone did not fit criteria for their analysis. And olanzapine could only be analyzed in their 12-month analysis, but was not any more effective than any other intervention. So really, before someone has had a first episode of psychosis, there really isn't much evidence for the use of antipsychotics until that episode happens. So since antidepressants and GABAergic agents weren't included in the meta-analysis, we'll kind of cover those now. There really isn't much in the way of controlled trials of antidepressants in individuals with early psychosis, and none looking at stress sensitivity in particular. Prior to this trial we'll cover, there have only been 3 randomized controlled trials of antidepressants. They were all like 6 or 8 week studies, so not enough time to really see if the SSRI would be helpful. And they were all primarily looking at reversing antipsychotic induced weight gain. So not really the aims of those studies, so not exactly super helpful until this 2019 study. So this Decipher trial of citalopram in first episode psychosis wasn't super convincing in its results, but is based on the idea that a longer duration of untreated psychosis leads to decreased BDNF in the brain, as well as hippocampal atrophy. So the duration of untreated psychosis has been shown to be a predictor of poor response to negative symptoms to antipsychotics. So the thought here being that antidepressants like SSRIs increase BDNF, promote hippocampal neurogenesis, and so may help with negative symptoms. And so that's what they were looking at. So this was a placebo-controlled trial of patients that had a first episode of psychosis, ages 17 to 28, who did not meet criteria for depression. And they looked at negative and depressive symptoms in their population. A couple of things to note. One is that there's a high attrition rate, which reportedly did not differ per group. The other thing that made me a little suspicious was this duration of untreated psychosis. It wasn't statistically significantly different, but the placebo group had 29 weeks versus 53 weeks, which in the next slide, I'll kind of point to why that makes me a little bit hesitant. So looking at the results of this study, only the avolition subscale on the scale of the SANS had statistically significant improvement compared to treatment as usual. And overall, there was only a trend towards reduction in negative symptoms per the SANS total score compared to placebo. This went from being 0.05 to being 0.04 when they imputed values for missing data. So again, not super convincing in terms of the results, though the authors did note that avolition is reportedly a predictor of some 12-month outcomes in patients with their first episode of psychosis. The effect size did seem to vary with the duration of untreated psychosis, with a greater effect size if you had a longer duration of being not treated, which kind of goes back to my little suspicion about the placebo group being 29 weeks versus 53 weeks for the treatment group. So you'd expect even more of a response for the treatment group. So the fact that there is not much is kind of discouraging. The rates of depression did not seem to differ per group. And the placebo group actually had greater improvement in depressive symptoms, though the authors think that this wasn't clinically significant based on effect size. All right, so just 2 more parts here. Going back to the mechanism of stress sensitivity, if we think that this is driven by abnormalities within GABAergic neurocircuitry, it would maybe make sense that intervening with GABAergic agents may help. However, the evidence is really not convincing for their use in schizophrenia, and even less is known in the early phases of illness. In my search, I couldn't find any trials of benzos in early psychosis or in high-risk cohorts. A Cochrane review in 2013 found no support for benzos as adjuncts to antipsychotics in schizophrenia. However, they also could not conclude that they weren't helpful and cited situations in which they have some utility, like anxiety and catatonia. So a little bit inconclusive there. I think overall the limited efficacy may be down to the poor selectivity of these medications for GABAergic receptor subtypes. And so they may be just too blunt of an instrument to really use successfully. They also have obvious misuse and overdose potential. And so just to wrap up here on interventions, this was just an aside I thought was kind of interesting. So again, going back to our hypothesized mechanism of stress sensitivity, we theorized that disruptions in GABAergic parvalbumin interneurons lead to downstream symptoms and complications. And so this study was just like a basic science study that introduced a novel modulator of select potassium channels that regulate the firing of these specific interneurons. So I included it because this molecule appeared to increase conduction through these channels, which are highly localized to GABAergic PVI. And the authors note that post-mortem studies of patients with schizophrenia had deficiencies of these potassium channels. So this study was just done in cell cultures, but to me, I think it suggests a movement towards more novel and directed therapeutic targets, which I think frankly is necessary kind of given the limited efficacy of what we have available right now. So we'll just wrap up here with a couple of takeaways. The first being that patients with early psychosis are at high risk of stress vulnerability. And this is irrespective of the number of significant life events they've got going on. Both biologic factors like neurobiology, GABAergic dysfunction, as well as psychosocial components like trauma play into this stress sensitivity. And stress vulnerability is linked to poor outcomes, social function, negative affect, as well as psychotic symptoms and the transition to full psychosis. So it's worth considering working in some stress sensitivity scales to your evaluations of patients with, being at high risk of a psychotic illness or in the early phases of illness, given their prognostic value. And the cyanide is the one that's used here in the prep clinic, so you might encounter it. Overall, the results on interventions in this population have limited efficacy and suggest the need for more novel or targeted approaches. Though right now it seems like CBT and family therapy for high-risk patients seem to have the most evidence. And so these are my references, and hopefully, I think we might have a couple minutes for questions, but that's all I've got. Thank you for your time.
Hi. Thank you, Dr. Kline, for this very interesting and important talk on stress sensitivity and early psychosis. Just want to say that I think you did a really wonderful job walking us through this really fascinating and quite complicated concept. Like you mentioned, this idea